Okay, so high risk. Usually we can associate a client's background, her medical or psychosocial, her living environment to high risk. But that's not always the case. It's not always the case. So who can tell me what these stand for? I've got some abbreviations up here. Who can tell me what NAS is?
Neonatal abstinence syndrome.
Good. Neonatal abstinence syndrome. What's MAS? It's another syndrome. Margot, do you know what this one is? You know what this one is. You just might not know the abbreviation. Okay, it's meconium aspiration syndrome. Okay. RDS?
Respiratory distress.
Yeah, respiratory distress. What about FAS? All of these were in the PowerPoint I already sent you.
Fetal alcohol, yeah.
Yeah, fetal alcohol syndrome. And STS. And it's not sexually transmitted anything. What's STS? Skin to skin. I don't know if it's an approved abbreviation. Okay. NEC is necrotizing enterocolitis. STS, again, I got it up here twice. APGAR, you all know the tool we use for initial assessment of the newborn. And then ABO is blood types. There's ABO and AB, ABO, okay, blood types, and RH incompatibility, and then electronic fetal monitoring. Okay, so labor and delivery, some complications. Please know what a reassuring electronic fetal heart pattern would be for a woman in labor. No tachycardia, no bradycardia. Heart rate between what and what? The normal fetal heart rate.
So 110 over 160?
Yeah, 110 to 160. Okay. Shoulder fetal heart rate pattern other than heart rate variability, moderate, 6 to 25 beats a minute more, accelerations, and maybe even early decelerations, but no late or no prolonged or no variable decelerations. Okay. Shoulder dystocia, we're going to talk about today, injuries and infections. So during labor and delivery. So if you have a 39-year-old, her age makes her high risk, right? If you look on the chart and you see your client is 39 years old, you know she's already high risk. Multipara, which could make her high risk, depends how many para and how she delivered them, any difficulties she's had in the past, and now she's a gestational diabetic. Okay, so what are her risk factors during labor and delivery? Let's come up with some risk factors for labor and delivery. What could possibly happen? Gestational diabetic.
What's it? Microsome, like a big baby. Microsome.
Okay, so if she has a macrosomia, what are some things we might see?
Like a large baby, like shoulder dystocia or.
Okay. Good. What else might we see?
Hypoglycemia.
Trauma, tearing, or
Okay, injuries to baby and mother, right? Lacerations, cervical tears, What else did somebody say?
Fracture clavicle, fracture humerus. And the nerve, I don't remember the name, but the nerve like on the neck, it could be damaged too. The
Called
baby's
the
neck.
yeah, it's called the brachial plexus injury. It's a group of nerves. Groups of nerves are called plexus. Okay, so it's the brachial. Okay, injury. Okay, what else?
Neonatal hypoglycemia.
Okay, and for the neonate, before we get to that, what's one more
Congenital
thing?
congenital
Respiratory
abnormal.
distress. Respiratory distress.
Before we get to the newborn, let's still talk about mother. What else could she be at risk for?
Preeclampsia.
Okay. And C-section, cesarean surgery. Okay. All of those things. Blood clots, deep vein thrombosis. So now let's talk about the baby. Because of the macrosomia, let me put that in here. So macrosomia affects mom and baby, right? Macrosomia. So with macrosomia, once again, we've got injuries to the baby we've already mentioned. What else? Somebody said it.
Respiratory distress.
All right. And then what's the other biggie?
Congenital defects.
Yeah, if mom during early pregnancy. Okay. But
Hypoglycemia.
Hypoglycemia. Hypoglycemia.
hypoglycemia. The reason I don't want to put congenital defects in here is because we're talking about macrosomia. Okay. We're talking about specifically macrosomia. Okay. Hypoglycemia. So those are the biggies for the fetus. Okay. So when we're talking about shoulder dystocia, recognizing it's occurring as a nurse, you have a gestational diabetic. She has a macrosomic baby. What are some things that you would see? What concerns you and what is not concerning you? Turtle sign. Okay. She's in labor, the baby is being in the stage 2, right? Baby's head is delivered, but there's a pause and we can't progress any farther. And what happens? The baby's head is beginning to protrude, and then you'll see that baby's head pull back up against that perineal wall. You can even see where their cheeks are being pushed. So it's being pulled back in, just like a turtle. And that's a sign of the shoulder is actually impinged or stuck under the pubic arch. Okay. Macrosomia. Baby could be a normal size in its mother's anatomy. She's got a narrow pelvis. Family history. If somebody else had this problem, a sister, her mother had this problem with delivery, sometimes we see an association with that. So ignore the Elizabeth thing, okay? But risk factors then are diabetics, gestational diabetics, because that's usually the diabetics that we see. Type 2, obesity, okay? Just large babies, more than 4,000 grams. That's about 10 pounds. Not quite. Okay. So some things we can do, our goals. So as a nurse, our expected management, right? Active approach to these clients. If you know they have a big baby, or you know there's been a family history, or you have a gestational, be prepared. Okay. Be prepared. Have extra help in the room. Okay. Think about the positions that might help the client deliver her baby without the difficulty of shoulder dystocia. And then know what to do if it does occur. Okay, so McRoberts maneuver. Lower the head of the bed, flex the hips and the knees to open up that pelvic structure. Okay. We could also have her get on her hands and knees. Sometimes that helps. Okay. And then the suprapubic pressure. You need to make sure after delivery that you're assessing not only mother for possible injuries from the dystocia and the shoulder dystocia, but also the newborn. Okay. Does a newborn, when you palpate the clavicles on both sides, do you feel any crepitus, which a cracking noise, a crackling sound? Okay. Or do you notice something different about that shoulder? Maybe the injury on that side of the neck, the brachial plexus was stretched, and that disrupts the nerve function of the arm. So you might see some paralysis of that arm. Depends how many of those nerves were affected to the extent of the paralysis. You don't have to know the difference between the different kinds of paralysis, like Erb's palsy and Klumpike's. You don't have to know the difference. Okay? But make sure you're assessing your newborn for injury. Some other complications of postpartum, we think for mother, we're thinking about blood loss. We've talked about this since week 4, haven't we? Postpartum blood loss as one of the #1 causes of mortality in the postpartum period is hemorrhage. Infections, especially with our diabetics, mood disorders, what medications we use. So postpartum complication of a gestational diabetic. So let's talk about blood loss. Okay. What is your priority in assessing a postpartum client?
Fundus?
What's your priority?
Bleeding.
Right, yeah, blood loss, bleeding. So what are some things you're going to assess right away? What things should you recognize if she's having some excess bleeding?
Level of
What is the fundus?
level of consciousness should be low, would be low.
That's a late sign. We want early signs. We're proactive.
How quickly is she soaking a pad?
Okay,
Type
that's
and
one.
color.
Okay,
The pulse will be increasing.
no, pulse is a late sign. Did you say pulse? That's a late sign. So
Okay.
soaking a pad.
Are we talking right after birth or?
Yes,
Blood pressure.
that's a late sign.
How about assist the fundus? If it's baggy, you massage
Alright.
it.
Let's do that. Yes, Joy. We got to assess the fundus. Okay. Remember, it's the uterine atony or the subinvolution. Okay. It's not contracting, subinvolution. Okay. Atony, #1 cause of bleeding. Lacerations and hematomas are the second leading causes of hemorrhage. Okay, so consider, I don't know if I can make this a different color or not, so not a very nice color. Consider the cause. Remember atony. So fundus, fully Pitocin. Massage that fundus, get the bladder empty, give her some medications, right? Pitocin, Methergin, misoprostol, Hemabate, IV access. So this is your priority actions. Okay, your priority assessment follows quickly by actions. Okay. Infections, postpartum infections. What kind of infections are we talking about? What are some postpartum infections?
UTI.
Okay, urinary tract infection. What would you recognize, or what assessment data would you collect?
Her urine output after her Foley was removed.
Okay, what about her urine output?
If
What's
it
a
was-
sign of urinary tract infection?
Pain when urinating.
Pain, dysuria, pain.
Tension.
Pain with urination, yeah, pain with urination. Okay, you might even see some hematuria. That's pretty significant though. You would probably have seen that in the Foley. Okay, so urinary tract infections. What else? Could be
Endometritis.
endometritis. So what's that an infection of?
That's going to cause the swelling in the abdomen. It's going to have the discharge and vaginal bleeding, stuff like that, fever.
Could mastitis
Okay.
be one, or is that pushing it?
Mastitis is one. So if you have a client with a fever, feeling malaise, maybe a little tachycardic, it's a sign of infection. So you have to determine what's causing the infection. Is it mastitis? Is it endometritis? Is it UTI? Right? So your client is going to be able to tell you a lot. They're going to tell you when they're having pain with urination. They're going to complain about mastitis because it's going to be a tender breast. And mastitis, there's going to be a reddened area on the soft tissue. Okay. Sometimes in the form of a pie shape. One area is erythemic. It's going to be warm to touch and tender. She's going to feel some malaise, have a fever, okay, flu-like symptoms. Okay. The same thing with endometritis. So the things that can cause endometritis are cesarean sections, right? If we don't treat our clients that are having a C-section with an antibiotic, they're at risk for uterine infection, which is called endometritis. Okay, same thing, a fever over 100.4 for 2 days in a row. So after the first 24 hours, 24 hours after delivery, then if the mother begins to show signs and symptoms of an infection, fever, lethargy, some tachycardia, not feeling good, then we're thinking about some kind of maybe endometritis, mastitis, UTI, or C-section incision infection or laceration infection. Okay. So endometritis, very foul vaginal discharge, tender abdomen. She might have retained tissue in there, so she might be bleeding more. Mastitis. How do we treat what teaching do we want to do for mastitis? How do we teach mastitis?
You can go into a warm shower
Okay.
Continue to
the blood
breastfeed.
can flow.
I'll continue to breastfeed, warm compresses. We need to keep the breast empty, or at least emptying. We don't want it to become engorged because it'll get worse. Okay, so we do want mothers, she can breastfeed even on antibiotics. She can continue to breastfeed. Okay, if she doesn't want to, and some pediatricians don't want her to, old school. Okay, if she doesn't want to, at least teach her to keep her breast empty, or at least prevent engorgement. Okay, she needs a supportive bra. So I snuck DVT in here. It's not going to be on your exam, but I thought we would review it because diabetic, gestational, type 2, type 1, is at risk for DVTs, okay, postpartum. So what would you see? What are some signs of a DVT?
Painful legs, swollen legs.
It's usually on one side, right?
Right.
So swollen, some edema, painful to touch, maybe pain without touching. What else?
Redness.
Okay, erythema in that area. Okay, so what would be your priority?
Do a Doppler ultrasound.
Okay, so we need to verify that that's what it is, but the clinical signs are pretty strong. Okay, so what's another priority that as far as nursing interventions?
Elevate the extremity, but don't put pillows under the knees.
Okay, so elevating, not necessarily elevating, but supporting, and no ambulation, right? Yeah, we don't want to dislodge the clot. If you see signs of DVT, you need to contact the provider, right? And have the client stay in the bed. So what's the difference between blues and psychosis? This is a postpartum complication.
Blues last up to 2 weeks and they resolve on their own after that.
Yeah, they're transient, temporary. They're very real though. Okay. About psychosis.
Those
Can
need intervention. Medical.
definitely need to intervene. Yeah. What kind of behaviors would you see?
A mother who doesn't want to pair with the baby. No bond with the baby.
They're going to have bizarre behaviors.
Okay, bizarre behaviors. A client that has a blues or a client with history of depression might not want to bond either. Okay, so psychosis is a more acute onset. Okay, more severe behaviors, more bizarre. Okay, depression, psychosis, both suicidal, infanticidal, homicidal ideation. Yeah. But goes with psychosis, it's very abrupt onset. Okay, bizarre hallucinations. So psychosis is an emergency. Okay, so contact the provider, consider the safety of the client and the all the staff. Your cohort, your coworkers. So this is just some more information about what you would see with mood disorders and the differences between the blues and depression and psychosis. Okay. So the newborn complications. Let's talk about newborn complications again in more detail. So if you have a client that had a difficult labor. Some decelerations were noted. And she comes in and is concerned about, you're concerned about the color of amniotic fluid, and you're even smelling an odor. You're going to check for fetal heart tones and do vital signs on mom every 2 hours. So you have a fetal heart rate of 156, no decelerations. Blood pressure is good, right? Pulse, respirations, temp, vaginal, and you observe and you notice that the vaginal discharge is large amount, thick green color. So what you first should come to your mind is meconium stained amniotic fluid. Risk for meconium aspiration syndrome in these situations. That can lead to fetal pneumonitis and or meningitis. Okay, even meningitis. Respiratory distress. So what are some signs of respiratory distress? So if you, I got ahead of myself. So if you were to have this client show up in your OB unit, what would you be doing at this point? Now that you know what's going on.
Give antibiotics.
To whom?
The mother.
I'd say the baby, because they're the one who's at risk for infection.
Okay, would antibiotics help this? This is pneumonitis.
Never mind. I was thinking of something else.
Okay, all right. So no, we don't necessarily do antibiotics, yes, but the most important thing is respiratory support, okay? So let's go work through this. Wait a minute. So we need to contact neonatal practitioners or the neonatologist and the high-risk OB people. We need to contact the neonatal nurses, the NICU nurses, to be involved in this delivery, okay, for respiratory support, okay? So that is the most important thing we need to be doing. We don't force suction newborns. We're not gonna, we can do oral suctioning, but unless there's very severe respiratory distress and we have to intubate, we try to avoid intubation, okay? We want the newborn to clear their own lung fluid, okay? So let's say you're taking care, you're working in the nursery, and the baby is fairly stable, but still showing some signs of distress. We're doing positive pressure CPAP, and the baby is still struggling. And we decide we need to do an X-ray. The X-ray shows broad spreading atelectasis. What's atelectasis? Anybody know what atelectasis is? Something you should have learned about in health assessment.
Is that a collapsed lung?
Okay, well, it's the alveoli themselves
Alveoli.
not being able to expand. Okay, and it could be from the pneumonitis, it could be from the meconium aspiration, it could be from a premature baby. Okay, not having sufficient surfactant. So in that situation, what we want to do is provide surfactant for that baby. Okay, we can give it through aerosol, bag the baby to get it into the baby's lungs, and that will help that newborn. Okay. So next complication during labor and delivery, and even in the postpartum period too, would be finding fetal heart rate 180 and minimal variability. Blood pressure, large vaginal discharge, thin, clear color, that's a good sign, okay? So if you have a temperature of 103, she's got an infection somewhere, doesn't she? What kind of infection? This is called chorioamnionitis. And so the infection, her water might have been leaking, her fluid, the amniotic fluid might have been leaking at home for a while. She wasn't aware of it. And she had some bacteria in the vagina or the urinary tract that was vertically transmitted to the amniotic fluid. So she developed chorio. We have to use antibiotics for chorio. What's our drug of choice for chorioamnionitis?
Penicillin. Penicillin.
Penicillin, yeah, penicillin. Penicillin. So what if you find deep variable decelerations and bradycardia of your fetus? Temperature is normal in this situation. What's variable decelerations? What's that a sign of?
Cord.
A cord prolapse, yeah, cord prolapse, good. Variable decelerations, and what is your primary action, intervention?
Like move or
Position change
Yeah, okay, what kind of position?
on the side.
Chest.
Knee, chest, or trendelenburg? Yes. So you're gonna push back on the presenting part because you're trying to push it off the cord. And then we need to do a C-section. Okay, the normal newborn. So the things that you need to understand about the normal newborn is what's skin to skin all about? What do we mean by skin to skin? Thermostability. Go ahead.
Keep your body temperature, thermostability.
Yeah, and we do that through skin to skin, don't we? So somebody tell me, you're in the labor room, labor and delivery room, and you're working with a nurse and you just got a new job and you're in there and they're getting ready to deliver the baby and the baby's delivered, the provider suction the mouth and nose, and a minute later clamps the cord and hands you the baby. What would you do?
Dry the baby.
Dry the baby, vigorously dry that baby, and then what?
Apgar.
You want to place the baby on the mother's chest or abdomen, okay? Skin to skin, okay? Put the baby on mom, okay? Skin to skin. Because we want thermostability, right? Cardiopulmonary stability, opportunity for breastfeeding, okay? Bonding. And then 1 minute, then we're going to do our Apgar. Okay, 1 minute we do the Apgar. So somebody give me an Apgar. Somebody tell me if we have a client, okay, I'll tell you about it and you tell me what the Apgar is, okay? You have a newborn 1 minute later and you observe baby's crying, baby's moving hands and legs. Feet are a little blue tinted, so are the hands. Heart rate is 140. Okay, and baby withdrawals from suctioning the mouth. What's your Apgar?
Is it 10?
9.
Say 9.
9. Why is it 9?
Because the hands are blue colored.
Yeah, the acrocyanosis, we got to deduct a point for that. Okay. What if the heart rate was 80? Baby's barely crying. The body is little cyanosis around the lips. Baby does move extremities, okay, and does do some withdrawing. What's your APGAR?
Is it 3?
4.
So some cyanosis around the lips would be a 1, right? Heart rate's 80. And baby is crying, but kind of a weaker cry. So that's 3 that you've lost, 3 points that you've lost. So it's going to be around a 7, 6 or 7. Okay. Just needs a little stimulation. Okay. And maybe some suction, mouth suctioning. Practice your APGARs. Breastfeeding. Now, this is normal, right? This isn't part of really high risk. This is nutrition. Okay. So breastfeeding. Can you name one client you would not want them to be breastfeeding? What is one client we know for sure? We
HIV
don't.
client.
Okay, a client with HIV with high levels of viral load. Okay, I did read some recent research that said if the client's been receiving antiretroviral during the pregnancy and her viral load is not detected, then they are allowing them to breastfeed. Okay, but for the sake of this class, we need to say no. Okay, so if a mother has received antiretroviral therapy during pregnancy to keep that HIV from being transmitted to the fetus, then after delivery, she needs to continue taking it, of course, but we also need to do the same for the baby. So we treat with IV retroviral for a newborn. Okay. There's nothing on your exam about that, but it might be on the HESI or the NCLEX. So breastfeeding, what other? Can you think of anybody else you would not want to breastfeed? You would not encourage to breastfeed?
Ebola.
Okay, maybe Ebola virus. Yeah. Okay.
A parent that's addicted to opiates.
Okay, someone who is on opioids, whether it's prescribed or not, and they're not on any rehab type partial agonists like buprenorphine, Subutex, or methadone. We definitely don't want them to breastfeed. Okay. So methadone is safe, and so is buprenorphine to breastfeed. But anybody else that's on any other drugs, we don't want to breastfeed. Not even cannabis. Some people think of cannabis as harmless, but not for pregnant women and newborns and children. Okay, so breastfeeding. When do you want to assess and teach breastfeeding?
1 to 2 hours after birth.
Okay, or actually you can do it, teach right away during skin to skin when baby has all those reflexes working. You can actually begin your teaching, your assessment of how well the baby latches on, position, how mother can hold her baby. You can teach right away. That is one big cat, Amanda. And a big furry one at that.
Yes, he is.
He's huge. Okay. So breastfeeding. So if the mother chooses not to breastfeed, what are some things you want her to know? If she doesn't, what would you teach a mother that chooses not to breastfeed?
The benefits there are with in the immune system of the baby.
Okay, so if you're still trying to educate her and trying to encourage her to breastfeed, there are a lot of benefits to breastfeeding. So there's immunoglobulins in the breast milk. Absolutely. What else is in the breast milk besides immunoglobulins that's good for the newborn?
Protein.
Iron? Or no, not iron.
Nutrition.
Okay, nutrition. Yeah.
Protein and antibodies.
Okay, we talked about immunoglobulins. Yeah, immunoglobulins and nutrition, but also there's digestive enzymes to help the baby digest the food. So pancreatic, amylase and lipase are both found in breast milk. Okay. So if she chooses to use a commercial formula, she's going to go to Walmart or to whatever store she chooses to go to. We need to make sure she chooses one that's iron fortified. Okay. Unless instructed differently by her pediatrician. And not to use cow's milk, right? Cow's milk doesn't have enough. Babies don't digest cow milk until they're at least a year old. And even then it's questionable. Okay. They used to feed babies, newborns, whole milk, thinking that they were doing giving them all they needed, but that doesn't give them all they need. It's hard to digest. Okay. So a commercial. Okay. So what if you had a client, let's go back. What if you had a client that's breastfeeding and she's having trouble producing milk? What could be some of the problems with that? She calls the office, she's at home, it's a week after she delivered, she's been breastfeeding, and she says, I don't think my baby's getting enough. What would your response be?
How many diapers?
Yeah, how many diapers? 6 to 8 diapers.
Okay, 6 to 8 diapers a day. Okay. What if she says, oh, I only had 4 diapers yesterday?
I don't think that's not a big deal. 4 diapers.
Well, we really want them to have at least 6 diapers. Okay.
Did you increase another breastfeeding?
Maybe she
Okay.
can feed first and then just use like a formula to do like to replenish the baby to whatever is left if the baby is still hungry. But
Okay,
breastfeed.
so first of all, you want to find out how often is she breastfeeding, right? How often is she breastfeeding? And then what is she eating? What is she drinking? What's her intake? So you have to do a full assessment of the situation. We might have to increase the times that she breastfeeds. What we could also do is have her breastfeed every hour for a while to increase her milk supply. Make sure she's eating before she breastfeeds herself. Eating herself, I'm eating before she breastfeeds. Okay. And then we can also have her pump between breastfeeding to stimulate milk production. So there's some just nursing things that we could teach our clients. Okay. Sometimes we can give a drug, Reglan, believe it or not, might increase. You don't need to know that. But think of the nursing things. You have to assess, well, how often are you feeding your baby? Are you breastfeeding? Does the baby seem satisfied after you finish breastfeeding? Okay. There's one other question you could ask her. Are you on a birth control pill? If she's on a birth control pill with estrogen, estrogen's going to diminish her ability to make milk because it diminishes prolactin levels. We need her prolactin levels, which is another hormone, to be higher to make milk, right? Prolactin makes the milk in the breast. Okay, so we need to know what her birth control method is. All right. So there's some other high risk. Somebody explained to me a scenario. Let's say you have, let me do it and then you can tell me. I have a baby that's being delivered and mom is just exhausted and we need to assist her a little bit because stage 2 has already been 2 hours long. Okay, so we're going to use a vacuum assisted delivery method. Okay, we're going to apply suction to the fetal head. The membranes are ruptured, the baby mother is fully dilated and effaced, the head is right there. And so we're going to assist in just a little manipulation, turning a little bit, and applying some pressure to bring that baby forth. What are some things that could occur to the fetus? Would it be a kaput or a cephalohematoma? What would be more likely to occur?
Kaput.
Kaput. Okay, kaput. We call it kaput because that second word is really hard to pronounce. Succedaneum. Okay, so a kaput is very simple. It's venous damage. Those blood vessels in the scalp can be damaged and they leak, and then fluid collects. So it's like having edema of the scalp. You know, you can press down just like you have ankle edema with renal failure or heart failure. You have pedal edema, hitting edema. Well, this is the head of the fetus. The vessels were damaged and fluid collect. And so you can press down. And the head is usually a different, misshaped a little bit. Okay. So we can explain to mom it's temporary. It will resolve usually within 24 hours. So that's a kaput. It goes all the way across soft tissue. So it's like an extra cap, an area. It doesn't have to be right on the head. It could be anywhere, right? Versus a hematoma. So would we necessarily get a hematoma from a vacuum assistance delivery? No?
No.
Maybe forceps or some other kind of hard labor dystocia. A development of a hematoma is not going to be recognizable before the first 24 hours. Okay. So which one of these would be more likely to cause higher levels of bilirubin?
Cephalohematoma.
Okay. So remember, a red blood cell. Let's dismantle a red blood cell. A red blood cell has hemoglobin attached to it, right? And that hemoglobin that's attached to that red blood cell is where the oxygen connects. Okay, so that supplies the tissues. When the red blood cells in a newborn don't live as long as they do in an adult, it begins to break down. So that hemoglobin disassociates itself. The red blood cells is broken down, so that hemoglobin disassociates itself from the cell body. And that hemoglobin then is further broken down into heme, which is iron, and bilirubin. Okay, so we have bilirubin circulating in the body. You have bilirubin circulating in your body, but your liver is functional and mature, and it can connect that bilirubin to a protein, and then it just released through the feces. Okay, and you don't turn yellow. Okay, if you have liver disease, then you might notice, and the worse that liver disease, the more increased risk that your skin begins to turn yellow, and it starts head to toe. Okay, sclera. Okay, so if you begin to notice sclera that's yellow, jaundice, or the forehead when you press on it, the nose when you press on it, yellow, then you know the bilirubin levels are a little higher than what they should be, because there's nothing from the liver. The liver's not able to provide a protein an enzyme to connect that bilirubin molecule to something to get rid of it. So it's just free floating in the circulation and the tissues. Okay, so hyperbilirubinemia, anytime there's red blood cells broken down, you'll have certain amount of bilirubin circulating. Okay, and if the liver's not working right, and for a newborn, the liver is immature. Okay, how can we fix it? How do we fix hyperbilirubinemia in a newborn? What do we do?
We put him under that light. I don't know what it's called, phototherapy, something like that.
I got ahead of myself. Here we go. Yes, we can use phototherapy, and that causes it's absorbed through the skin, and it causes that bilirubin to be converted into a different form, and I don't understand it, but once it's reduced to or changed to a different physical form, and then it can be released out of the body. So phototherapy, ultraviolet light, and we can use Billy lights, Billy blankets, Billy this and Billy that, but we have all kinds of tools that we can use, but sunlight does the same thing too. So we can encourage moms with sunlight. So if you have a baby that's developing jaundice, 3 days after delivery, is that a pathological or a physiological? What kind of jaundice is it?
Physiological.
Yeah, it's normal, isn't it? It's kind of normal, nothing to be super concerned about. And we begin our interventions, and then the baby's going to be monitored on an outpatient basis once the baby goes home. But what if the baby is born and jaundice develops within the first 24 hours? It's more pathological, isn't it? Something is causing hemolysis or the breakdown of those red blood cells early. Or baby is born with jaundice, which is rare because mom's liver takes care of the bilirubin. But shortly after delivery, if baby becomes jaundiced, we're worried about what?
Liver problems.
Actually, we're worried about ABO or RH incompatibility. Okay, RH, ABO, blood incompatibility. If we've got early jaundice, pathological jaundice. So blood, babies and mother's blood somehow mixed during the pregnancy or during the delivery, and the antibodies were there to begin to destroy the newborn's red blood cells. Okay, or she wasn't she was sensitized to in a previous pregnancy. In other words, she already had a baby that was positive RH, and she did not get a RhoGAM. And so with this pregnancy, it wouldn't be unusual for her to have a baby with some jaundice. Okay. Respiratory distress in the newborn. Let's see, what else do I have here? So if you have a client with diabetes and their baby is born hypoglycemic or with some respiratory distress, what are some things you would see in the newborn to lead you to suspect respiratory distress? And it would be shortly after delivery. What would you see that would concern you?
Shaking hands.
Irritability.
Would you say, Lene?
Irritability.
Irritability. Okay. Respiratory distress. They're having trouble breathing. What would you see?
Tachypnea.
Oh, tachypnea. Yeah. Respiratory rate above what?
Above 160.
That's
sorry.
the heart rate.
I'm sorry.
Respiratory.
30.
Okay.
Above 60. Yeah. 30 to 60 is normal. Okay. 30 to 60 is normal. So anything above 60, tachypnea could be a sign of respiratory distress. Good. What else? Make sure you watch some of the videos I sent you.
Nasal flaring.
Nasal flaring. Yeah, they're trying to do whatever they can to bring air in. You know, it's not too different from what an adult would look like. Nasal flaring. Tachypnea, breathing faster. They're having trouble breathing. What else?
Are they using accessory muscles?
Yes. And what are those accessory muscles?
The intercostal muscles.
Okay. intercostal, subclavicular muscles, all these muscles around the chest that they're using to try to expand their chest. So intercessory, nasal, flaring, tachypnea, what else?
Grunting and maybe cyanosis.
Okay, grunting and yeah, cyanosis. Oh dear. Okay, respiratory distress, definitely. So what would you do?
Oxygen, non-rebreather.
Okay, so for a newborn, they don't necessarily need as much oxygen as they do.
Would you put them in semi-prone or sideline position?
Okay, so we're going to provide ventilatory support. Okay, ventilatory support. In other words, positive pressure respirations. Mask with a bag, right? Assist ventilate. So when baby breathes, we're gonna keep some air inside so the baby doesn't exhale quickly. Okay, we want to pause, it's hard to describe, positive pressure ventilation. Okay. Sometimes that's all they need for a while, just positive pressure with low oxygen flow. Why don't we want to give too much oxygen to a newborn? Anybody remember?
It causes retina damage, doesn't it?
Yeah, retinal vessel damage. Yes, it does, because those blood vessels on the retina are very fragile and they might not be mature even at the birth. So we don't want high pressure of oxygen, high oxygen pressures, we call them. It means percentage in the blood because it could actually damage the vessels.
Could it pop the alveoli?
We want the alveoli to pop.
If it's too much, I mean like literally pop.
Okay, so bronchodysplasia or bronchial, when a baby is on a lot of oxygen, a lot of ventilatory support, it can actually cause a dependency on that and actually damage the lung tissue to the point where it's more fibrotic and it doesn't do the exchange, the gas exchange as efficiently. Yeah. So we could damage the lungs. What are some signs of hypoglycemia in a newborn? What would you see?
Tremors?
Okay, not too different than the way we are as adults. Jittery, irritable, maybe some lethargy. Okay, what would you do? What if mom called out and said, my baby's jittery, diaphoretic, or not diaphoretic, but
We need to
clammy?
feed the baby.
Feed a baby. So breastfeeding. Okay, so any client that is breastfeeding, we're going to teach them to feed that baby every hour to 2 right after delivery to keep those sugar levels above 40 milligrams per deciliter. Okay, monitor that glucose in that baby. Teach mom about the symptoms of hypoglycemia in a newborn. Okay.
Professor,
Yes,
you said keep it above 40, what?
40 milligrams per deciliter. Mhm. I think some of the research says 45, but your text says 40. Well, I tell you what, we need to take a break since we haven't taken one. Let's take a break. 45, let's say 10 till 5. And we'll finish just a couple more slides here, and then we're going to practice math together. I've got some problems for you to work on, okay?
I left a question in the meeting chat in the box.
Okay, Lene, is that you asking me? Okay. So cyanosis around the lips. As long as the baby is breathing and the body isn't blue, I still think we could give a 1. Okay. I would give a 1 for that.
Okay, I guess my confusion is, on the chart, it says blue extremities and pink body. But if the extremities are pink as well as the body, but then they have cyanosis around the lips, then it'll still be a 1 and not a 2.
Right.
Okay.
Yeah, because it would be associated with the respiratory status, not the skin appearance.
Okay.
Okay.
I thought like extremities would be more severe over just the lips. Okay.
Because the extremities, it's about perfusion and maturity of those vessels in the extremity. It's not about oxygenation. Okay. And usually
Okay,
if a
yes, I
baby,
remember you mentioning
yeah,
that.
yeah. So if a baby is having respiratory distress, we're not going to just see blue lips. Okay. We're going to see the lips maybe turning blue, and then that spreads very quickly around the body. So it would be, I mean, it's kind of rare just to see blue lips. It would be, if we don't correct it, it could get worse, and then it would be, appearance would change to a 0.
Okay.
Okay, does that help?
Yeah, because when you explained the lips would be hypoxia as opposed
Yeah,
to low perfusion to the extremities because the vessels are
right.
not mature enough for them.
Yeah,
Yeah,
yeah.
that makes sense. Okay, thank you.
You're welcome. Okay. So neonatal abstinence syndrome, what are you going to teach your mother to expect? You want to encourage her and you want her involved in the care of her newborn. And if she has been using some kind of substance that she's become dependent upon, and the fetus is also dependent upon that, so the newborn will be. So it depends on what drug she's been using, how often she takes it, and when her last dose was, as to when we would expect to see some kind of withdrawal symptom or sign, actually. So number one, tell me, what signs would you see if you have a newborn that's been exposed to methamphetamines or opioids or some other potent drug?
High-pitched crying.
Okay, so high-pitched crying is definitely a sign of central nervous system inflammation, irritability. Okay, what else?
Jittery baby.
Jittery, meaning very hypertonic and rigid. Yes. Tremulous. You know,
Sometimes seizures.
sometimes seizures. Yes. Yeah. What else? Make sure you watch that video that
Difficulty sleeping.
difficulty sleeping or fragmented sleep, difficulty falling asleep or falling asleep and then waking up with a jerk, just very fragmented. Their sympathetic nervous system, their systems and their functions in their brain are disorganized. Okay, it's hard for them to process information. It's without feeling loss of control. Okay. So when you think about some of the normal reflexes that we have, they're going to be disorganized. So sneezing,
Are they gonna
inappropriate,
also have loose stools?
loose stools and diarrhea. Yes. Yeah.
Not eating
Yawning,
like they should.
sneezing, things like that. What?
Not feeding like they should be, and vomiting.
Okay. So the coordination it takes to suck, swallow, breathe. Newborn can normally do that because their reflexes are mature and they've not had any damage to the brain. But a baby that's had some kind of injury, that whole organization, that coordination has been altered. So it's hard for them to coordinate their sucking and swallowing. Good. Okay. So these are some of the things that we need to teach mom to look for. Okay, if she begins to see withdrawals, it's really important, especially if she takes a long-acting drug. These newborns we usually keep in the hospital across the board 5 days to make sure we catch them if they're going to go into withdrawals. Gives us opportunities to work with the client, get some support services involved, other professionals involved. Maybe a psychotherapist or someone who specializes in that area to help them work with them with their baby. Okay, we don't want them to feel threatened. We don't want them to have fear about somebody taking their baby away. We want to be able to work with them because babies are best with moms and dads. Okay, so if we can do it in a safe way, we're going to do it, even if it has to mean daily nursing visits at home to assess mom and her baby. Okay. So what are some interventions that can help the newborn? Non-pharmacological interventions when you have a neonatal abstinent baby. Quite a few of the students. In fact, I was starting to grade some of the teaching plans. It's like everybody chose substance use disorder, and some of you really picked up on some of the nursing interventions and what we can do with our client.
I know a quiet, dim room helps decrease the stimuli for a baby.
Yeah, so because they have that sensory intake, They don't know what to do with that information. So the more we can reduce stimuli, the more comfort they have. Okay, so reducing a dark room with
Throttling them.
swaddling, yeah, control. It's like an external control. Swaddling a dark room. It almost seems like the opposite of what we should be doing sometimes, leaving the baby alone. You know, isolate them in a dark, quiet room.
What about
they-
the pacifier?
The what?
Pacifier.
Pacifier, yes, yes, definitely. Pacifier. Non-nutritive sucking to get rid of some of that energy. Okay. So rocking, swaddling, rocking vertically a baby sometimes helps regulate their system, makes them feel like there's some control. Okay. Good. So the necrotizing enterocolitis, remember the things that you would see if a baby's gut is not being perfused, if it's being injured, if it's beginning to die, if it's not functioning well because of poor perfusion or too many antibiotics, the gut itself is being damaged. So it's almost like a bowel obstruction in an adult. Distended abdomen. Okay, a baby with a distended abdomen, poor bowel sounds, minimal bowel sounds. Okay, it's an emergency. Okay, surgical intervention. Okay, so these babies need to have an NG tube so that we can keep the air in the stomach removed to help reduce some of the distension. Bacteria put off gases, and that's why we have that large bowel. So that's your necrotizing enterocolitis. Breastfeeding babies are a little protected from this because cord clamping delay improves perfusion with the more blood that the baby has. So it helps to perfuse the gut. So delay cord clamping and breastfeeding reduces risk for a baby to develop NEC and reducing the amount of antibiotics we give babies. Okay. Any questions about any of that? Retinopathy of prematurity we talked about. Okay, let's see here. Stop sharing if I can find my share screen. I don't know why it separates. Okay. So it's a little bit after 5. Let's work on some math together to prepare you. Oh, I say that when I'm playing with my screens. So sometimes you all struggle with just some of the basic math stuff. So let's work on a couple together. So this is, I think I put this in your announcements. A listing of math practice. It's a document. Okay. So when we look at an order, and I don't have medications in here, but if I write you an order and ask you to give your client, and I'm looking at this one here. If I write an order and ask you to give client 0.5 milligrams subcutaneously now, okay, so you go to the Pyxis and you find a vial, and it's labeled 5 milligrams in 2 ml. You have to calculate, well, then what volume do I need to drop in my syringe to give this medication at the proper dose? So I set it up for you. Don't make this any harder than what it really is. So it's a proportion. Okay, if you have 5 milligrams and 2 ml on your vial, but you only need a half a milligram, what's the volume that you would need to give the correct dose?
Would it be 0.2?
0.2.
It would be
0.2.
0.2. You could almost do that in your head. Now, some people can't. They don't go in that direction. Okay,
Move
but
the
you need,
decimal.
because it's not going to always be that easy. So what if you have 0.4 up here? And you still have the same strength, 5 milligrams 2 in 2 ml, but you only need 0.4 milligrams.
0.16.
Isn't it?
Okay.
One? Look hard. Come in here, Dada. Oh,
Macy. Okay, so what is the answer?
0.16.
0.16.
0.16. Okay, 0.16. And it depends on the situation. You might want to go with 0.2, round it up. Okay.
I got
So-
0.2.
Okay. So that's how you set all of those up. All of these. What if you come across one like this? 400 micrograms subcutaneously, and your vial says 0.2 milligrams.
Just convert
So
the
you got-
milligrams to micrograms.
It'll be
Yeah,
two-
go ahead and convert your milligrams to micrograms. So you're working with the same number. So if you have 0.2 milligrams, how many micrograms does that equal?
200.
So then you can set it up the same way that you set these up here. Okay? Okay, just remember you got to convert it. Same way with the 500. 1,000 let's see, it would be 1,000 micrograms. Another kind of problem, I ordered you to infuse 80 milliequivalents of a certain drug, and it's mixed in 250 mLs of a solution. I want you to get this solution into this patient within 3 hours. So in this picture, the 80 milliequivalents is not something we need to focus on. We're more interested in the volume, right? It's just about the volume to get in. What if I said, feed your client 5 apples that are in 1,000 of the solution over 2 hours? You need 1,000 to go in, and she'll get 5 apples. Okay, so that would be over 2 hours, it would be 500 an hour. Infuse 900 micrograms and 100 ml. It's about the 100 ml that we don't have to do anything with the 900. So what's 100 ml over 40 minutes? How would you set that problem up? In other words, how would you set that up to infuse over an hour? And that would be your rate. Okay, so it would be,
Would that be 100 mil divided by 0.67?
I don't know what the answer is. I just threw these problems
I
together.
think 150 milliliters an hour. Okay, because 20, 40, 60, and then 50, 100, 150 an hour.
Okay. But that's how you would set it up, 100 over 40, and then X or question mark over 60 because you want the hourly rate so you can set your pump up, even though you're going to get it in 40 minutes. So if I told you to ingest 2 cookies in 30 minutes, eat 2 cookies in 30 minutes, how many cookies would you have eaten in 4 hours? This is easy because you could just do fingers, right?
16 cookies
Yeah.
in 4 hours.
8 cookies.
That's a lot of cookies.
2, 4. Yeah, 4 times 4.
Okay. What if you have an order to infuse 500 ml of a solution labeled 100 milligrams per 50 ml? So you've got this bag that's 500 mLs, okay? And the label on it says that there's 100 milligrams every 50 mLs, okay? But you're supposed to infuse it at 250 an hour. How many milligrams will the client have received after that first hour? See, this takes several steps, doesn't it? But it's the same idea, okay? So you have a solution labeled 50 mLs, okay? 100 milligrams per 50, okay? So if we're supposed to infuse it at 250 an hour, so you have to set up your proportion. And then you're going to look back at the milligrams.
Be 500 milligrams, right?
Can you type that, the whole proportion?
So what's the first step we want to do?
$100 over 50 equals X over 250. Then you can just cross multiply it out.
I got a question. So when you get a question that's asking you to infuse 500, because I always get questions like these wrong. So do you leave out that 500 and just focus on the 100 over the 50 times 250, or?
But if you read the question, it says infuse 500 of this
Yeah.
solution, at 250 an hour. So it's going to take 2 hours to get it in. But they're asking you how much of that drug will they receive after just 1 hour?
Right.
You're going to be given it for 2 hours, but the question is how much of that drug will you get in 1 hour if you're running it at 250 an hour?
Yeah, what I was asking is when you're like doing your problem, do you add that 500 or do you just? Okay, all right.
They're not asking you anything about the 500, really. It's just what you receive. If I give you a bag of 500 solution, here's your bag. There's 500 mLs in here. And the label says that there's 100 milligrams for every 50 mLs, okay? In this bag, you're supposed to be infusing 250 mLs every hour. So we set it up. We want to find out how many milligrams are in 250 mLs. Okay? Because that's how many milligrams they'd receive in 1 hour. By the time they get to the end of the infusion, it would be double that amount, right? There is a question on the exam. It's not like this, but it's similar. So make sure you're understanding the problem, okay?
Okay, thank you.
And sometimes if you just draw a picture of the solution, if you're a visual learner, draw a picture of it so you know what you're working with. There's something process that goes on up here that you need to visualize that bag. Okay. All right. All right, I think we are going to stop right here. Do you have any questions?
No, ma'am.